Hello, everyone, and welcome to this presentation. As you can see, this presentation is on coding changes for hospitalists that took place in January of 2023, or just earlier this year. And also, we're going to spend a little time reviewing some other frequently used codes by hospitalists. My name's Tom Fredrickson, and I'm the System Vice President for Physician Enterprise Hospital Medicine Operations. I'm going to be one of your presenters today. And I'd like to have Carrie, my co-presenter, introduce herself quickly.
Thank you, Dr. Fredrickson. Again, my name is Carrie Forshak. I am a coding compliance trainer from the Pacific Northwest Division, part of the Virginia Mason Franciscan Health FMG coding department.
Thank you, Carrie. Thrilled to be presenting today with Carrie.
Thank you.
We're going to start off with a reflection, as always. The reflection for today is from Benjamin Franklin. This is from his journal. What good shall I do today? What a good practice to ask ourselves this every day. Benjamin Franklin would plan his day around this statement. He would make plans around this, and then every evening he would take a time to both reflect, and as you can see from his notes there, not only to reflect on what good he did that day, but also have some time to unwind. Music, diversion, nice conversation. So I thought that's a very good advice for all of us. Ask ourselves what good we can do, reflect on what good we did do, and then make sure we have time for things that we love and that recharge us. Okay, so our agenda. You can see it's divided into three parts. The highlight are the new rules in 2023. The basic codes for initial visits, follow-up visits, and discharges are decreased from 18 to 11. So we'll talk a little bit about that. Review medical decision-making and also how to bill based on time. We're going to review some important rules, some of which haven't changed, but they're very good to review, and you can see the list there. And then lastly, we're going to go over some codes that are sometimes neglected by hospitalists, but give us all a chance to get credit for the great work that we're already doing in most cases. So before we move on, I want to highlight a little bit about why. So this is from CMS. Why were these changes made? And you can see these three dot points. It's to reduce the administrative burden of documentation, which I think we can all relate to. The second is an attempt to eliminate, and I would say it's probably more decrease than eliminate, but it's the right direction, note bloat. And I think everyone appreciates that. And then the last piece is how can our notes focus more on what matters in patient care? So I think as we go through this presentation, all of you will see that at least directionally, some of these changes from CMS are helping us achieve these really good objectives. So now at this point, I'm going to turn it over to Carrie.
Thank you. All right, these next couple slides will go over those major changes that you're going to be seeing in 2023. The baseline codes have decreased from 18 to 11 codes. So you will see in this table here in 2022, you were billing the observation care. They have now combined those with the hospital inpatient care. So your code set 99218 through 992220, you're going to now be looking at the initial hospital inpatient and or observation care for those initial visits. The subsequent is now combined into subsequent hospital inpatient or observation care. And then observation discharge has been deleted as well, and you will only bill the hospital inpatient or observation discharge services. So again, the hospital observation care is no longer, they have deleted all of that code, those code sets, and you will just only be utilizing the initial hospital inpatient or observation care, the subsequent hospital inpatient or observation care, and the hospital inpatient or observation discharge services. Also, those same day admin discharge codes, times have changed on those. So that's the code set 99234 through 99236. You will want to look at the times as those times have changed. So this slide goes over what that new criteria is for choosing your level of service. So in the past, we looked at history and exam, medical decision-making. We are no longer looking at this history and exam. It is only going to be you only want to document what is medically appropriate. So right now, you're just going to be choosing that level by medical decision-making or total time. So again, that history and physical no longer play a role in the level of service selection, but making sure you document a medically appropriate history and or physical, and that is still included when performed to support the medical necessity of that visit or continuity of care to follow through with making that medical decision making. You still want to make sure that you do have a history and a physical documented so that it will help you in that medical decision making portion. And also to make sure that you always start your note with a chief complaint or stating a reason for that visit.
Okay, now, one thing to note, along with these changes, going from 18 basic codes to 11 basic codes, the work RVUs associated with the remaining 11 codes, 18 codes to 11 codes, the work RVUs associated with those 11 codes have changed, except for in one instance. One instance, they stayed the same, but in all the others, the work RVUs either went up a little bit or down a little bit. So that leaves hospitalists asking the question, since it's very common, and in fact, I think in most instances, our compensation is tied somewhat, and in some cases quite a bit, to work RVUs. So how? So that's kind of a natural question. How is this going to affect our work RVU output given the same work? So I want to highlight this analysis a little bit, and this analysis is an attempt to look at the typical hospitalist. Now, this might not be your typical hospitalist. I know there's lots of different care models. There's nocturnists, there's admitters. But let's just say, for the sake of argument, that you have a typical hospitalist that sees 15 patients, 2 admissions, about 80% of those admissions level 3, the rest level 2. Follow-ups, 10 follow-ups, about half of those level 3, most of the rest level 2, and maybe 1 level 1. And then 3 discharges, 2/3 of those high level, greater than 30-minute discharges. Okay, so that hospitalist on that day, what's the effect? Well, the effect is the work RVUs are increased by about 10%. Or if you multiply that, say the hospitalist works 168 shifts a year. So that's 4,800 work RVUs versus about 5,300 work RVUs. So the net effect, and this isn't even counting the fact that the observation codes that were sprinkled into this analysis have had slightly lower work RVU values as well. So the net effect is, on average, we think that for the same amount of work, hospitalist work RVUs are going to be increasing about 10%, which is great. It means the CMS is recognizing the value of what we're doing as hospitalists, that it is a lot of hard work. Now, I will want to tell you, though, that that increase is not, well, you saw some codes have increased work RVUs, some have decreased. Net, it's an increase, but rounders, the follow-up codes and the discharge codes are up, while the initial visit codes, those are the ones that tend to be down. So if you have a rounder admitter model, the rounders will tend to go up a little bit. The nocturnist shifts or the admitter shifts, those would tend to go down a little bit. So when you're thinking about compensation and how to structure things in your group, it's probably good to keep this in mind. Okay, I'm going to turn it back over to Carrie.
Thank you. So these next couple slides, we're going to go in detail into those elements of code selection. So this first slide talks about your MDM, your medical decision making. And this is the first way that you can select your codes. MDM is defined by the following 3 elements. The first element that we look at is the number and complexity of problems that you're addressing during that encounter. And then the second element is the amount and or complexity of data to be reviewed or analyzed. The third element is the risk of complications or mortality of the patient management. The level of service is still chosen by the two highest elements. So out of those three that we just discussed, two of the highest will choose your level of service. And then another way to look at that is the second highest element that you have. The key to this in your documentation, in your thought process, is to use I statements, tell the patient's story, document why you chose the management or diagnostic options, document daily why the patient needs hospitalization, and also to be aware of copy and paste or anything that will cause note inconsistencies. So to sum that up, basically document why you're seeing the patient on that date of service and why it's necessary for that level of service that you're billing. And then these next couple slides are going to go into detail on those three elements. This first slide talks about the number and complexity of problems addressed. So as a hospitalist, more than likely, we're going to be looking in that moderate to high MDM level, sometimes low, but what you really want to look at is in that high level, if you're seeing a patient that has one or more chronic illness with severe exacerbation, progression, or side effect of treatment, or an acute chronic illness or injury that poses a threat to life or bodily function, that's going to fall in that high level under number of complexity and problems addressed. If you are seeing a patient or if you're rounding and they have two or more chronic stable illnesses or an acute illness with systematic symptoms or an acute complicated injury, that falls in that moderate MDM for number of complexity of problems addressed. This next slide goes over the amount and or complexity of data to be reviewed or analyzed. This is that second element that we look at in determining the level of medical decision making. You will note at the top here where it says each unique test, order, or document contributes to the combination of 2 or combination of 3 in category 1 below. So what that means is this is basically the data, the workup that's being done for that patient on that data service. So in that moderate category, you must meet at least one of the 3 categories. So category 1 includes test, documents, or independent historian. So you must have 3 from the following: a review of any prior external notes from each unique source, review of results of each unique test, an ordering of each unique test, or assessment requiring independent historian. When they speak on unique tests, that could be an X-ray, a lab, an MRI, any unique test that has its own CPT code falls into that category. So if you order 3 unique tests, that would satisfy that moderate medical decision making for this element of data. Category 2 is independent interpretation of tests. So if you are independently interpreting a test that was performed by another provider or qualified healthcare professional that is not separately reportable by you, and it's documented, not just saying that you have reviewed the report, but you have independently interpreted that test and gave your own impression, your own interpretation of that test, that would qualify for that moderate medical decision making if you had only done that and only that on the data service. Category 3 is discussion of management or test interpretation. So what this means is if you have any discussion of management of that patient or test interpretation with an external physician or other qualified healthcare professional or appropriate source that would not be separately billable, that would qualify for category 3. If you are discussing anything regarding that patient management with an external physician, that making sure you document that in the patient's chart on that data service so you get credit for that. The difference between moderate and high for this element is if you must meet 2 of these 3 categories. So category 1, if you have 3 tests that you have ordered or reviewed on that data service, and you must also meet either category 2 or 3, or vice versa. You could do an independent interpretation of a test and have discussion and management with another qualified healthcare professional. That would qualify for that high level of data to be reviewed. The last element that we look at is your risk of complications and/or morbidity or mortality of patient management. So these are, again, just some examples that CMS has given us regarding the risk of complications, and really your documentation will support how sick, what the risk of complications, and the morbidity or mortality of the patient management. And again, remember that this is on the data service that you're billing for, and what your documentation should reflect for that data service. In that high risk, some examples that they give are any patient that is on any drug therapy that requires intensive monitoring for toxicity, that qualifies for high risk. If there is any decision regarding any elective major surgery and that patient has any identified risk factors, if they are identified risk factors would include hypertension, diabetes, anything of that sort, and you've made that decision regarding an elective major surgery, that falls under high risk. A decision regarding any emergent major surgery would also fall in high risk. If you have made a decision regarding hospitalization, which they are already, or if they are not admitted yet, or they're not in the hospital yet as of yet, but also the escalation of hospital care. So if you have to escalate their hospital care because their condition is worsened, that qualifies for high risk. If there's any decision regarding the do not resuscitate or de-escalate care because of poor prognosis, putting patient on comfort care levels, that would fall in that high risk also. And then the last example they give are the parental controlled substances. So if any of that is being given on that data service and you're documenting it, that falls under that high risk of complications. And all those 3 elements you put together, and you whatever you come up with, the highest level would be 2 out of those 3 would be your level of service that you would select. And then this next slide here goes into time-based billing. So if you choose to bill based on total time, it would be the total time of the calendar day for the patient encounter. Some examples of what is included in that total time are face-to-face with the patient or caregivers, any phone time with caregivers, preparing for any specific patient services, discussion with another provider regarding that patient, any care coordination or documentation regarding that specific patient. You will include all of that time in your total time, in making sure that you document the total time and then being able to bill based on that. Teaching learners does not count, but providing care with learners does. And learner time alone does not count, together with your providing care does. And APP time is an additive, so you want to be careful to document your in and out times, because you cannot overlap any in and out any time. So you could not add that, any overlapping time.
Okay, so a little bit more about billing on time. So hospitalists in general, I think, will be billing on medical decision-making, have in the past billed on history, physical, and medical decision-making, but we at times do bill on time. But part of the not so great news is all the times are up, okay? So it's going to be a little harder and a little more challenging to bill based on time that it has been in the past, just because it requires more time. And here's a table of how the times have changed, so to speak. So you can see, for example, subsequent hospital, inpatient, or OBS care used to be 35 minutes. Now it's 50 minutes. So that's a little bit higher of a threshold. But you know, if you do more than 50 minutes, then that's still a possibility. And where this also comes into play is in prolonged services. And we have a slide on that in a little bit.
This next slide here gives you a breakdown of any patient that's in the hospital less than the 24-hour stay. So this is kind of a workflow for how you would choose that code selection depending on how long they've been in the hospital and when they're discharged, depending on the calendar date. So we'll just go through this. The length of hospital stay, if they've been there for less than 8 hours and they're discharged on the same calendar day as admission or start of observation, the code that you would bill would be that initial hospital service. And you'll only bill that initial hospital service. You would not bill any discharge that day as well. Well, you are just going to bill that initial hospital service only. If they've been there for more than 8 or more hours and they're discharged on the same date as admission or start of observation, you would bill the same day admission and discharge. However, making sure that you document 2 encounters and 2 notes. So 2 notes are required. Any patient more than 8 hours, or I apologize, less than 8 hours, but it's a different calendar date than the admission or the start of observation. Again, you're going to bill that initial hospital level service only. Patient that's there 8 or more hours on a different calendar date than the admission or start of observation, you're going to bill that initial hospital service on day 1, and then you can bill the discharge code on day 2. So that's just a little breakdown of how and when you want to bill these services. In this next slide, we're going to talk about the medical necessity. So your documentation has to demonstrate why that visit was necessary and the care in the hospital that is necessary, and that a lower level of care would not be appropriate for that patient. And the last thing would be the care that you prescribe the care you prescribe is necessary in terms of the level of care, interventions, tests, medication, anything that is ordered by you for that patient, that it's medically necessary. And the way to do this is to have a concise statement of the reason of your visit, your chief complaint. So making sure that every date of service that you see that patient, even if it's your day 10 in your rounding on that patient, that it reflects why you're seeing the patient on that day and that it's medically necessary. And making sure you document your reasoning for that. If they continue to need, why they continue to need hospital care.
Okay, now we're going to shift to some specifics that hospitalists encounter frequently in their care and in their documentation. The first is some basics around APP shared and split visits between physicians and APPs. First of all, I think a number of you have heard about this substantive portion rule. The good news is that substantive portion rule has been delayed a year. So it's not in effect for 2023, but it may be effect in 2024. So more to come on that. And what that basically says, in order for a physician to bill for an APP physician split or shared visit, the physician has to document the majority of the time. Okay. So we are still with the traditional rules that similar to what we've operated under now for a number of years. And that is where the physician has to document at least one of the 3 key components: history, exam, or medical decision-making in its entirety. So I think as a practical matter, this is usually going to be medical decision-making. So keep in mind, we just heard from Carrie, about the complexity of the problem, the complexity of the data, the risk, those three categories. So if you're going to bill a high-level visit and it's a split shared visit, then the physician has to document the high level of at least two of those three. Also a reminder, this has to be on the same calendar day to be a split or a shared visit. And then last, I'd advise all of you to kind of go through, look at your attestation statements, your dot phrases, make sure that they reflect these rules, because that will make it easier for you to follow the rules. Next is working with residents, which a number of you have the opportunity and pleasure of doing. So the first kind of rule here is your note, the physician's note, needs to tie in to the resident's note. Okay, so there needs to be, I am referring to the note of the resident, name of the resident, this date and time. Okay, so that's key. Different from the APP split shared, this can be on the same day or it can be a previous day. So the example is the night float resident admits a patient at 10 o'clock at night, leaves an H&P, the attending rounds with their team at 8 o'clock the next morning. The attending can tie in to the resident note from the previous evening for that day of service, being the next day, the day when the attending is seeing the patient. The documentation must demonstrate, again, this is your attestation statement, that you were actually there on the date of service and that you were actually evaluating the patient and that you were involved in management. In other words, you decided on management or you discussed it with your team, that it was at a minimum a collaborative effort, and that's all documented. So the bottom line is you can use the resident's note in your documentation for all of this, but your attestation statement has to document those 3 points above. So again, like split shared visits, it's a good idea to review your attestation statements, dot phrases, whatever you're using, so that you're making sure that those tools that you're using make it easy for you to follow the rules. So the last one, working with students, a little bit different rule for working with students. So students can document their observations, history, physical exam, medical decision-making in the medical record, and as part of the learning process, certainly are encouraged to do so. But the teaching provider needs to independently document their work. And the only work that they can count on 100% for the student is the history. So they need to either certify the physical exam, that they performed the physical exam and agree, or redocument it, that they did medical decision-making and agree, or redocument it. Okay, and like the residents, you can tie into the student note from the same day or the previous day. And then certainly, just like with the previous two, make sure that you're using attestation statements that help you to follow the rules and to do it appropriately. And last, these are the CMS rules. Your particular institution, whether that be your hospital or your educational institution where the students come from, they may have more stringent rules. So you need to make sure that you're aware of those rules as well and follow them. Okay, I'm going to turn it over to Carrie for this little piece about a pretty frequently encountered situation for hospitalists where they are asked to consult on a patient who's in observation. Go ahead, Carrie.
All right, thank you. So yes, this is just a little example that you may or may not run into. So we'll review this. A patient is in observation and the hospitalist is a consultant. So what do you want to use when you run into this situation? You're going to use outpatient codes. So if you have a patient that's in observation and you are called to be the consultant, if it is an initial visit, you would bill the outpatient new patient codes, which is code set 99202 through 99205, with the exception if your partner, anyone in the same group or same specialty, had seen that patient in the last 3 years, you would use the established patient visit code set. So just keep that in mind. Any follow-up visits, if that patient is still in observation, you're going to then transition into those established patient visit code, outpatient codes. As you do with the inpatient codes, you're going to use total time or MDM to bill. The MDM is the same, again, for inpatient and outpatient codes, with the exception of level 2, new patient or established. That MDM is straightforward instead of low. So just think, if I can't even meet the low criteria into two categories, you're going to fall to that straightforward level 2 visit. So below, you will see what the timeframes for those new patient visits and established patient visit outpatient services are. So for a 99204, your documentation, if you're documenting by total time, would need to support 45 to 59 minutes. And that level 5 new patient is 60 to 74 minutes. For the additional visits or follow-up visits for established patient services, that level 3 is 20 to 29 minutes. Level 4, 30 to 39 minutes, and that level 5 is 40 to 54 minutes. These next couple slides we're going to talk about prolonged services. This is a new code for 2023 for the inpatient setting. So you're going to use 99418 for any 15-minute increment of time beyond expected time of the highest level of service. So what that means is you can only use this code with your inpatient code 99223, 99233, and 99236. That initial visit, this subsequent or rounding visit, and your same day discharge admit visits. You cannot use this prolonged service code with discharge only services. So again, you only can use this prolonged service code once you have billed that highest level of service, and also making sure that you document total time for that level of service, and that you're billing based on total time for that service. So when you are doing outpatient codes, as the previous slide, we were discussing the observation patient, the same rules apply, but the code for that is 99417. That is a prolonged service code for outpatient services. Below that, I apologize. Below this is just a time chart, kind of gives you an idea of when you can bill for those prolonged services. So that initial visit, the 99223, you have to meet that threshold of 75 minutes. And then if you get to the 90 minutes, that 15 minutes over, you can bill the 99418. And every 15 minutes after that, you can bill an additional 99418. So Medicare does have specific coding for these prolonged services, and they have broken it out into there's 3 codes for you as an inpatient or observation codes. It's going to be G0316 for outpatient, again, that where you're the hospitalist is a consultant and the patient's in observation. That G code is G2212. You essentially, depending on your division coding leader and what rules they have in place, will determine if you're going to be using the 99418 or the G0316. There should be crosswalks in place, just making sure that you're aware of these codes and reaching out to your division coding leader to see what one would be appropriate in your division to be using.
Okay, now we're going to shift gears a little bit to some activities that hospitalists often perform, and they need to capture this work in their documentation and therefore also in their billing. So this falls into the category of getting credit for the great work that you're probably already doing. Okay, so the first is advanced care planning. So we'll start off with a definition. So it's face-to-face discussions that cover any of the following. If you're helping a patient or a patient surrogate if the patient doesn't have capacity to do advanced directives or other kind of relevant documents. If you're having complex code status discussions, if you're talking about goals of care, any types of discussion that have to do with advanced care planning, goals of care. We often think of these as palliative care type discussions or partnering with the patients on their goals of care. Okay, so that's really what this is. So as you can see, this is what we do all the time. So what's important to remember is this is an add-on code. Okay, so if you're doing history, an initial visit, and you spend half an hour in addition to, you do medical decision making, and it's a level 3 H&P, but you also spend an additional half hour as an example, really talking someone through goals of care, talking about whether they would want tube feedings or not, or whether they want an ICU admission or not, or code status. You're really helping them, patients or their surrogate, decide that, then that's the opportunity to build advanced care planning. If it has to be more than 15 minutes. So 16 to 45 minutes is the 99497. And then the add-on code for each additional 30 minutes, you add on 99498. Okay. So that's advanced care planning. So the take home, one final point on this, what do you need to document? It's very straightforward. You need to document what you discussed, what decisions were made, who you discussed it with, other people who were present and helped in the conversation. And then if there were documents or things like that that were filled out, to make sure that those things get in the medical record and are referenced as well. So this is pretty straightforward, and I think a real opportunity and sometimes a missed opportunity for hospitalists. Okay, smoking cessation. This is another one. This is very easy. Another thing that we do all the time. This is again an add-on code. If you're doing it during the course of a follow-up visit, for example, you bill based on medical decision making. But if you also spend anything more than 3 minutes in smoking cessation counseling, you can add this code as well, as long as you document it. 99406 for 3 to 10 minutes. And if it's over 10 minutes, 99407. This one, unlike advanced care planning, you do one or the other, not both of them. And then the documentation is easy. You really just have to document what you discussed, how you counseled them, why, the potential health effects of the patient continuing to smoke, and then what you recommended as intervention. Did you recommend a patch? Did you recommend counseling? Whatever you recommended to help the patient quit smoking. And it's billable once per stay. Okay. And then one final thing to kind of remember about this code is if you're going to bill for this, don't forget to include in your problem list, and again with your billing, the ICD-10 code for nicotine dependence or some code similar to that. Okay, the next one of these we're going to cover is critical care. And again, this is a missed opportunity as well, I think, in many instances. So first of all, let's go to the definition. What CMS, what do they define as meeting the threshold for being able to bill for critical care? Well, if you are stabilizing a patient that has one or more vital organ systems, that if it's not stabilized, has a high probability of something happening that's life-threatening. Okay, so the patient is going to have a serious consequence, including a potentially imminently life-threatening consequence, unless you intervene to stabilize organ system failure or potential failure. So when do you think about this? You think about this when you're admitting a patient to the ICU. You think about this when you're transferring a patient to the ICU. You think about this when you're admitting really any patient that has a failure type diagnosis. Think renal failure, think respiratory failure, think coma, those types of diagnoses where unless, or even major strokes, any type of shock diagnosis, anything where you are actively stabilizing someone that has unless you stabilize them, could deteriorate quickly into something that was life-threatening. So the threshold for this is 30 minutes. That's the 99291. And then the add-on after 74 minutes for each additional 30 minutes is 99292. Now, a few of the particulars: document in and out time, start time and end times. The time has to be in the calendar 24 hours, the calendar day, but it doesn't have to be contiguous. So you can do 20 minutes between 9 and 9:20, come back at 11 and do another 30 minutes. You have 50 minutes. You've met the 30-minute threshold. Some other things is APPs can build this code. And new starting last year, it can be billed as a split or shared visit. And another change in this code is it used to be that two different providers, for example, an ED physician, you're seeing a patient in the ED is providing critical care. Say they document between 9 a.m. and 10 a.m. You document between 9:45 and 10:45. Those 15 minutes didn't used to count where there was an overlap. Now they do, as long as you meet all the other elements. So you don't have to be as worried about, stepping on the toes of the ED physician or the ICU physician, as long as you are doing a separate service that is stabilizing the patient. Okay, so that's critical care. So don't miss the opportunities to do this and to look for opportunities. Now, one thing to keep in mind, though, is in general, if you are called to the ED to evaluate and admit a patient, and you spend an hour and a half admitting a complicated patient, and it is during one time frame, you usually can't bill an initial visit and critical care. You have to decide, well, is this an initial visit or does it meet the threshold for critical care? Now, that's different. If you admit a patient at 9 in the morning, 3 in the afternoon, something happens and they crash. They have some sort of adverse drug reaction or something along those lines, get hypotensive, you transfer to the ICU. In that instance, you can. That it's separated in time and it's a different event. So then this one is code blue. This is another one that we miss. And what this really is if you're running the code, okay? So it's pretty straightforward. The documentation is straightforward. You just have to document, that you ran the code. And then, of course, there's a lot of other documentation that goes in with a code blue. And then you can document this 92950 code blue or CPR code. It's just simply being there, being part of the team, stepping in for 5 minutes doing CPR, that doesn't get it. But if you're actually running the code, it gets it. Now, a little bit about using this code in critical care. You can do them both, but you have to do both, right? So for example, if you run the code, and then after you run the code, the patient survives and has a pulse, and then you spend the next hour with the resuscitation from the code, well, then you can bill code blue and you can bill critical care. But you can't bill critical care just for doing a code blue if you're going to bill the code blue. Okay, now just a little bit, we're kind of on the home stretch here, a little bit about some of the work RVUs for some of these add-on codes that we talked about. These haven't changed. I just want you to be aware that some of these are pretty high value work RVUs, but all of them are really worth your time and effort. You're putting in the time and effort to do the service and to provide great patient care. The additional amount of documentation and then dropping the code is really quite minimal, and you really need to be documenting it anyway. And then a little bit about the outpatient codes, the work RVU values that Carrie taught us about. And this is a link to a number of additional resources. If you want to read more about these changes that took place, we'll make sure that this presentation, both the PowerPoint and the recording, are available on the Acute Care Clinical Institute Google site in the hospital medicine section under coding and documentation tips. So you can look at any of these references. And then last, I just want to thank everyone for listening and thank my co-presenter, Carrie. And then invite, if you do have questions, don't hesitate to contact one of us with questions. And then also, you may have noticed, it's fairly common for hospitalists to bill for procedures or bedside ultrasound. We didn't really include anything on this, but here's an invitation. If any of you out there would like to partner with us and create some education around that, we'd really enjoy that. So thank you, everyone.
Thank you. I really appreciate you including me and allowing me to present with you.